Pathology and Pathophysiology. 2.1 Basic Principles and Mechanisms of Disease. Inflammation and Repair. Inflammation is the reaction of vascularized tissue in the body to local injury or insult. It is a protective attempt by the body's defense mechanism to remove the harmful stimuli and return the tissue to its normal structure or function. Inflammation can be caused by numerous injurious stimuli, including the following: chemical irritants or toxins, mechanical or physical trauma, altered or damaged cells, microorganisms. Clinical signs and symptoms of acute inflammation include the following: redness, fever, swelling, pain. The inflammatory response that is produced by the body involves two distinct components, vascular and cellular. Vascular component. The vascular component of the inflammatory process begins with the initial injury. Following injury, the body increases blood flow to the site through dilation of the arterioles. Dilation of the arterioles, in turn, ultimately leads to dilation of the capillaries and venules. In normal states, the capillaries and venules allow the passage of only small molecules out of the vasculature into the surrounding tissue, retaining macromolecules, such as cells and plasma proteins, inside the vessel. In acute inflammation, the endothelial lining of the microvasculature is altered, thus allowing increased permeability of macromolecules into the tissue space. With this increased vessel permeability to macromolecules, there is also movement of body fluid, which causes swelling or edema at the area of injury. Cellular component. Along with vasculature changes that occur during the inflammatory process, numerous cellular changes are also taking place. As fluid is lost into the tissue space, large amounts of red blood cells, white blood cells, and platelets remain behind, causing blood viscosity to increase. This increase in viscosity causes a phenomenon called margination. Margination is a process in which white blood cells, or leukocytes, relocate from their normal central location in the bloodstream to the periphery along the endothelium wall. After margination progresses, leukocytes eventually adhere to the endothelium lining before emigrating from the blood to the tissue, where they are responsible for limiting the harmful stimuli and beginning the process of repair. Mediators of inflammation. Histamine is stored in the granular tissue of mast cells. Once released, histamine produces vasodilation and increased vascular permeability. Hormone factor is stored in an inactive form in plasma. Once activated, this plasma protein triggers the activation of 4 different cascades or systems important to inflammation and repair. The coagulation cascade leads to thrombin formation, which converts fibrinogen into fibrin, ultimately leading to clot formation. The kinin cascade leads to the production of bradykinin. Bradykinin is a peptide that causes vascular dilation and increases permeability. The fibrinolytic cascade involves the conversion of plasminogen into the active protease plasmin. Plasmin has 2 important functions: degradation of fibrin clots and activation of the complement cascade. The complement cascade has many important functions. It produces proteins that form the membrane attack complex, which attack harmful microorganisms. Additional activated proteins in this cascade are mediators of inflammation, causing vasodilation, increasing vascular permeability, promoting chemotaxis and phagocytosis, and initiating histamine release. Arachidonic acid is a fatty acid found in many cell membranes. 2 different pathways metabolize arachidonic acid, which produces potent inflammatory mediators. Prostaglandins and thromboxanes are produced from arachidonic acid through the cyclooxygenase pathway. Prostaglandins induce vasodilation and increase vascular permeability. Thromboxanes facilitate platelet aggregation, which is important to the healing and repair process. The lipoxygenase pathway results in the production of leukotrienes. Leukotrienes initiate chemotactic activities for white blood cells, cause vasodilation, and increase vascular permeability. Hemodynamic disturbances. Hemodynamics is defined as the function of blood flow or circulation and the forces involved. Alterations or disturbances in the normal pattern of blood flow can be harmful to the organs and tissues of the body. Examples of disturbances in circulation include the following: edema, congestion and hyperemia, hemorrhage, thrombosis, embolism, infarction, shock. Edema. Edema is the abnormal accumulation of fluids in the interstitial spaces of cells or tissues. To understand edema, one must understand the distribution of water between the body's fluid compartments. In the normal adult, approximately 50 to 60% of lean body weight is composed of water stored in two basic compartments. The intracellular compartment contains approximately 2/3 of total body water. The extracellular compartment stores the remaining 1/3 of total body water. The extracellular compartment is further divided into the interstitial space and plasma space, which are separated by the capillary wall. Normal exchange of body water from each compartment is controlled by hydrostatic and osmotic pressure, which is regulated by plasma proteins. Disruption of this normal exchange explains the etiology of edema. Causes of edema include the following: increased hydrostatic pressure, decreased osmotic pressure, increased vascular permeability caused by inflammation, obstruction of lymphatic channel, sodium retention, congestion and hyperemia. Congestion and hyperemia are increases in blood volume in a given tissue or vessel. Hyperemia is an active process in which blood flow is increased to a given area. An example of this process can be seen in acute inflammation. Congestion is a passive process in which the drainage of blood from a given area is interrupted. An example of congestion can be seen in valvular stenosis. In this disorder, blood volume is increased in the cardiac chamber preceding the valve that is failing to open properly. The process of congestion may become a chronic condition leading to permanent damage of the affected tissue. Varicose veins are an example of chronic congestion. Hemorrhage. Hemorrhage is the loss or escape of blood from the circulatory system. Accumulation of this lost blood may be external or enclosed within the tissue space of the body. A hematoma is referred to as the accumulation of blood within the tissues, and can range in severity from mild, e.g., a bruise, to more severe, e.g., a subdural hematoma. Petechiae are pinpoint hemorrhages, and LT 0.3 cm, seen most commonly on dermal or mucosal areas. Purpuras are widespread hemorrhages slightly larger, 0.3 to 1 cm, than petechiae and usually found under the dermal surface. Ecchymoses are larger, more than 1 cm, often blotchy hemorrhages that are also found on mucosal or dermal areas. Hemorrhages can be caused by trauma, vascular wall damage resulting from disease, or malfunction of the body's normal mechanism to maintain hemostasis such as clotting. Systemically, the significance of hemorrhages depends on the site, rate, and volume of blood loss. Thrombosis. Thrombosis is the pathologic process of formation of a blood clot within the circulatory system. The formed clot is referred to as a thrombus. Thrombus formation results from three factors known as Virchow's triad: decreased blood flow, injury or abnormality of the endothelial wall of the vessel, changes to the normal properties or processes of blood coagulation. Thrombi can form in either the venous or the arterial portion of the circulatory system. Because of high pressures on the arterial side of the system, most thrombi are formed by an abnormality of the vessel wall, e.g., atherosclerosis. However, on the venous side, blood flow is of lower pressure, and most thrombi there are formed because of decreased blood flow. The effect of thrombus formation can vary depending on the site and extent of occlusion. Thrombi may eventually be broken down by fibrinolysis, causing little harm. They can propagate and cause vessel occlusion, which leads to tissue damage or death, or they can embolize and move elsewhere in the circulatory system. Embolism. An embolism is the transportation of a detached mass from one area of the bloodstream to another. Most emboli are formed from blood clots and are referred to as thromboembolus. Most commonly, thromboembolus are formed within the deep veins of the lower extremities. They eventually become dislodged and flow through the right side of the heart, terminating in the pulmonary arteries and causing severe obstruction. This condition is known as a pulmonary thromboembolism. Emboli can also be found in the arterial system, most commonly originating from the chambers on the left side of the heart. Cardiac abnormalities, such as atrial fibrillation, increase the risk of embolism. Infarction. Infarction is the process of forming an ischemic necrosis within a tissue or organ. Ischemia is a lack of adequate blood supply to an area of tissue. Persistent ischemia can result in necrosis, morphological changes indicative of cell death, in that area. The etiology of infarction is most commonly associated with thrombus formation in the cardiovascular system, leading to various vascular diseases. Atherosclerosis is an example of a vascular disease leading to infarction. Atherosclerosis is characterized by thickening of the arterial wall by lipid plaques. Old plaques eventually calcify, thereby narrowing the lumen of the artery, favoring thrombus formation on the plaque surface, obstructing normal blood flow. Shock. Shock is a serious condition involving decreased perfusion of tissues and organs because of inadequate blood flow. Signs and symptoms of shock can include cold, mottled skin, mental status changes, and oliguria. The etiology of shock can be divided into 4 basic groups. Hypovolemic shock is due to inadequate circulating blood volume, most commonly caused by hemorrhage or trauma. In hypovolemic shock, cardiac output, CO, is reduced because of decreased venous return, and systemic vascular resistance, SVR, is high because of compensatory vasoconstriction. Distributive shock is also due to an inadequate circulating blood volume. However, fluid is not actually leaving the body as is seen in hypovolemic shock. Infections, septic shock, anaphylaxis, anaphylactic shock, and medications, neurogenic shock, are common causes of circulatory vasodilation leading to this type of shock. CO is usually normal to elevated, and SVR is reduced in distributive shock. Cardiogenic shock is due to cardiac malfunction and is most commonly seen in patients suffering myocardial infarction or cardiac arrhythmias. CO is reduced, and SVR is increased. Obstructive shock occurs when normal blood flow is interrupted or obstructed. Pulmonary embolisms and cardiac tamponade are examples of this type of shock. CO is reduced, and SVR is increased. The goal of therapy in patients with shock is to restore blood flow to organs and tissues until the underlying cause can be corrected. Shock can potentially progress through 3 stages. Non-progressive stage. Reflex neurohumoral mechanisms are activated, and normal circulation is restored. Progressive stage. Tissue and organs remain hypoperfused, thereby increasing damage and decreasing the likelihood of compensation. This condition can be seen in cases with severe blood loss. Irreversible stage. This stage occurs when the body has sustained injuries beyond repair by therapeutic intervention. Developmental defects. Developmental defects are defined as those originating in the embryonic period. Most developmental defects are discovered at birth. However, they can affect an individual at any point in the life cycle, from birth to adulthood. The etiology of developmental defects falls within 4 general categories. The result of genetic or chromosomal abnormalities, intrinsic. The result of an environmental agent, extrinsic. Multifactorial reasons, intrinsic and extrinsic. Unknown or unidentifiable origin, idiopathic. Developmental defects can be divided into 4 significant subtypes. Malformations are defects in normal development as a result of an abnormality of intrinsic cause. Deformations are defects in the form, shape, or position of a body part resulting from abnormal mechanical forces placed on the fetus during development. Dysplasias refer to defects attributable to an abnormality in the cellular organization or arrangement. Disruptions are abnormalities of normal growth and development caused by extrinsic exposures. Genetic and chromosomal abnormalities. Defects of genetic origin can be classified as numerical or structural. Numerical abnormalities involve defects caused by missing or extra chromosomes, aneuploidy. Aneuploidy has multiple causes, however, it is most commonly caused by non-disjunction during the process of mitosis. Down syndrome, trisomy 21, is the most common numerical abnormality. In Down syndrome, 3 copies of chromosome 21 are present. Structural abnormalities involve missing or additional genetic material attributable to deletions, translocations, inversions, and duplications of chromosomal segments. The Philadelphia chromosome seen in some patients with chronic myelogenous leukemia is an example of a structural chromosomal defect. In this defect, translocation of chromosomes 9 and 22 occur. Abnormalities caused by environmental factors. Exposure of the developing fetus to environmental agents or substances, often called teratogens, may cause developmental defects. The exact mechanism by which teratogens cause harm to the developing fetus in most cases is unknown. Teratogens may include drugs, chemical agents, infectious processes, radiation, and maternal disease states. Many drugs, including alcohol and chemical agents, are well-known teratogens causing a wide variety of effects. Retinoic acid is an example of a teratogenic drug. It causes craniofacial deformities, cardiovascular anomalies, and neural tube defects. Microorganisms that are present in the mother are often capable of crossing the placental membrane and subsequently infecting the fetus. Rubella, herpes sim, Plex virus, varicella, and human immunodeficiency virus are a few examples of infectious teratogens. Radiation exposure during pregnancy may cause growth and mental retardation, as well as other developmental defects. Maternal disease processes, such as poorly controlled diabetes mellitus and hypertension, are known to cause deformities such as limb abnormalities and congenital heart defects. Critical factors affecting teratogenicity include the period of development when exposure occurs, the dosage and duration of exposure to the teratogen, and the genetic makeup of the exposed subject. Exposure of the embryo to a teratogen during the period of tissue and organ formation increases the likelihood of major congenital anomalies. Both the dosage and duration of exposure to a given teratogen are important, however, not all teratogens exhibit similar dose-response relationships. A single exposure to a very large dose may be more harmful than multiple exposures to a lower dose of the same teratogen. Neoplasia. LS the overgrowth or abnormal proliferation of cells of a tissue. A neoplasm, also known as a tumor, is an abnormal mass of tissue attributable to uncontrolled cellular proliferation. Many similarities between neoplasms and other disturbances of growth exist, making terminology difficult. The following are terms used in growth disturbances. Related definitions. Many similarities between neoplasms and other disturbances of growth exist, making terminology difficult. The following are terms used in growth disturbances. Agenesis, failure of organ formation during embryo development. Aplasia, failure of organ or tissue development. Hypertrophy, enlargement or overgrowth or tissue because of an increase in cell size. Hyperplasia, enlargement in the size of an organ or tissue because of cellular proliferation. Atrophy, breakdown or decrease in size of a given body tissue or organ. Metaplasia, change in cell type usually caused by an adverse stimulus. Dysplasia, abnormality in the maturation or differentiation of cells within a tissue. Characteristics of neoplastic cells. Two types of neoplasm exist: benign and malignant, which differ in their growth pattern and behavior. Benign neoplasms characteristically are slower growing tumor that tend not to invade the surrounding tissue. Benign tumors do not have the ability to spread to the other sites of the body. Malignant neoplasms grow more rapidly than their benign counterparts, often invading surrounding tissue, causing disruption of normal function. Malignant tumors have the ability to metastasize, spreading to another site within the body and forming a secondary tumor. Metastasis. Some malignant tumors possess the ability to spread to distant sites of the body, usually through invasion of bloodstream or lymphatic system by the growing tumor. Once entry into the blood or lymph is gained, tumor growth continues, eventually separating into small emboli. The small emboli are carried along with the normal flow of blood or lymph until they reach a point where passage cannot occur. When the emboli become lodged, tumor growth resumes until invasion of the surrounding tissues occurs, thus, the tumor gains access to a secondary site. The lung is the one of more common sites of secondary tumors spread through the bloodstream. This condition is most often seen with malignant tumors at sites of good systemic venous drainage such as the bladder, prostate, breasts, and colon. Etiology of neoplasm. Research into the cause of neoplastic growth suggests that alterations, or somatic mutations, in DNA, deoxyribonucleic acid, sequenced by carcinogens ultimately result in the disruption of normal cell proliferation and death. Carcinogens are physical or chemical agent capable of causing genetic mutation. Examples of known carcinogens are as follows: tobacco and tobacco smoke. Radiation, e.g., ultraviolet rays from the sun. Viruses, e.g., human papillomavirus. Asbestos. Certain pesticides. Certain heavy metals, e.g., lead. As previously indicated, the formation of neoplasms involves mutation in the regulatory genes controlling cell growth and elimination such as proto-oncogenes, tumor suppressor genes, genes that regulate cell death, and DNA repair genes. Proto-oncogenes. Proto-oncogenes are genes with multiple functions, most importantly coding for proteins that control cell proliferation, differentiation, and elimination. Defective or muted forms proto-oncogenes are called oncogenes. Oncogenes may result in uncontrolled production of growth factors, leading to rapid and unnecessary cell growth. Several mechanisms exist for the transformation of proto-oncogenes into oncogenes. Point mutation. A single nucleotide change in the DNA sequence that result in a change in a single amino acid in a protein. Gene amplification. Overexpression of the encoded protein. Chromosomal translocation. Inappropriate expression of the gene. Tumor suppressor genes. Tumor suppressor genes are responsible for inhibiting cell growth, division, and death. Mutations of tumor suppressor genes result in loss of function, thereby causing the cell to ignore normal inhibitory signals. Tumor suppressor genes are recessive, meaning both normal alleles must mutate before uncontrolled growth can occur. Apoptosis regulating genes. Apoptosis is the normal process of programmed cell death resulting in elimination of cells from an organism. Genes regulating apoptosis are responsible for promoting and inhibiting this normal process. Mutation of this gene type may result in the failure of cells to die, thus causing accumulation. DNA repair genes. DNA repair genes are responsible for correcting errors that may occur during cell duplication. Effects of neoplasms. Local effects of tumors on their host are often related to the size and location of tumor and can cause tissue destruction and obstruction can occur with benign and malignant tumors. Systemic effects of tumors may be related to abnormal hormone production, nutritional deficiencies, and infection. Hormonal effects produced by neoplasms in endocrine glands may be life-threatening. For example, overproduction of insulin caused by an adenoma of the pancreas may result in fatal hypokalemia or hypoglycemia. Hematologic deficiencies, such as anemia, often occur in malignancies. Anemia can occur through many mechanisms. Directly, anemia may be caused by bleeding caused by the invasiveness of the tumor on body tissue and vessels. Metastatic tumor growth can also invade bone marrow, thereby causing a suppression of normal function. Cachexia is a wasting syndrome resulting in loss of body fat and lean body mass. It often occurs with malignant neoplasms. Cachexia results in generalized weakness, weight loss, anorexia, and fever for the tumor host. 2-2 Pathophysiology of disease states amenable to pharmacist intervention. Hypertension. Hypertension, a leading cause of death in the United States, is defined as a repeatedly elevated blood pressure exceeding 140 mmHg, systolic, or 90 mmHg, diastolic. Hypertension is classified as primary, also called essential, or secondary. 1. Primary hypertension is a much more complex condition in which no specific cause can be identified. Approximately 90 to 95% of hypertension cases are considered as primary hypertension. 2. Secondary hypertension is a disorder in which the cause is unknown. Renal artery stenosis, chronic renal disease, and hyperaldosteronism are few examples of cause of secondary hypertension. The maintenance of blood pressure depends on two factors: cardiac output, systemic vascular resistance. Alterations increasing one or both of these factors may lead to hypertension. Most commonly, hypertension is caused by increase in SVR. Resistance is increased by a reduction in vessel size, vasoconstriction, or increase in blood viscosity or volume. CO is increased by conditions affecting heart rate or stroke volume. Discussed next are a few factors that may affect CO or SVR, thereby causing hypertension. Abnormalities of the renin-angiotensin system. Abnormalities of the renin-angiotensin system can result in hypertension. Renin is secreted by juxtaglomerular cells of the kidney in response to decreases in renal arteriolar pressure of blood flow. Renin is responsible of converting vascular resistance. Sympathetic nervous system. The sympathetic nervous system is important in the regulation of normal blood pressure. This process of blood pressure regulation is controlled through stimulation of adrenergic receptors, alpha and beta, by catecholamines. Any disturbance of the sympathetic nervous system may cause hypertension. Natriuretic hormone. Atrial natriuretic peptide, ANP, is secreted by the atria of the heart in response to increased blood flow. ANP increases urinary excretion of sodium and water, thereby causing a decrease in blood pressure. In addition to its renal effects, ANP is also thought to affect vascular smooth muscle by inhibiting the sodium-potassium ATPase pump. This inhibition increases the intracellular concentration of sodium and calcium, thus inducing vasoconstriction. Endothelial dysfunction. Numerous vasoactive substances are produced in the vascular endothelium. Any dysfunction of the endothelium may lead to alteration of vascular tone, potentially causing hypertension. Nitric oxide is a potent vasodilator released by the endothelial cells in response to changes in blood pressure. It has been suggested that oxidative stress may cause a deficiency in nitric oxide, thus causing hypertension. Endothelial cells also release a vasoconstricting substance called endothelin. Numerous vasoconstricting agents, such as angiotensin II, vasopressin, and norepinephrine, have been suggested to increase the release of endothelin. Overstimulation of the production of endothelin may cause hypertension. Diabetes mellitus. Diabetes mellitus is an endocrine disease in which the body does not properly produce or use insulin, resulting in hyperglycemia. Insulin is necessary for the transport of glucose into cells, where it is stored as a glycogen to be used for energy. In normal physiology states, insulin is produced by beta cells of the islets of Langerhans of the pancreas. Insulin release is adjusted in response to serum glucose levels. In addition to glucose uptake, insulin stimulates amino acid uptake and, thus, protein synthesis by muscle. It can also stimulate fatty acid storage in adipose tissue. Diabetes mellitus is classified into two primary types and two secondary types, however, only the primary types will be discussed in detail. The primary types are as follows. Type 1, formerly known as insulin-dependent diabetes mellitus. Type 2, formerly known as an insulin-independent diabetes mellitus. Secondary types are as follows. Gestational diabetes. Other specific secondary types, including drug-induced types and those related to genetic defects of the beta cells, genetic defects in insulin action, exocrine pancreas disease, endocrinopathies, and infections. Symptoms of diabetes mellitus may include polyuria, polydipsia, polyphagia, fatigue, and weight loss. Type 1. Patients with type 1 diabetes mellitus have a permanent loss of insulin production. Type 1 accounts for approximately 10% of primary cases of diabetes mellitus. Most cases of type 1 result from an immune-mediated destruction of beta cells of the pancreas by T lymphocytes. Hyperglycemia results, caused by an insulin deficiency. The remaining cases are idiopathic in nature, because autoimmunity is not evident in this group. Current research suggests that both genetic and environmental factors are responsible for triggering autoimmune destruction. Onset of disease occurs most commonly in children and adolescent, although occasionally the disease may not be present until adulthood. Type 2. Type 2 diabetes mellitus involves a combination of a relative resistance to the action of insulin and a deficiency in its secretion. Type 2 accounts for approximately 90% of primary cases. Although the specific cause of type 2 diabetes mellitus is not known, research does show that it is not immune-mediated. Type 2 is a genetic disease, however, environmental factors are believed to play an important part in its onset and perpetuations. Complications of diabetes mellitus. Acute. Previously mentioned symptoms of polyuria, polydipsia, and polyphagia are all a result of hyperglycemia and may be seen in both type 1 and type 2 patients. Polyuria occurs when the threshold for glucose reabsorption by the kidneys has been exceeded. This condition results in osmotic diuresis, which increases in urine output. Dehydration occurs, which stimulates thirst. Polydipsia, increased hunger. Polyphagia, may be a result of significant calorie loss when glucose is lost in the urine. Diabetic ketoacidosis, DKA, is a potentially life-threatening complication. It occurs more frequently in patients with type 1 disease. DKA occurs when severe beta cell destruction has occurred without supplementation of exogenous insulin therapy. In the absence of adequate insulin therapy and an increase in counter-regulatory hormones, glucose levels begin to increase. Despite this increase, the necessary uptake of glucose cannot occur in muscle tissue, fat, or the liver because of the lack of insulin. As a result of this lack of necessary energy source, a process called lipolysis occurs. Lipolysis is the breakdown of lipids, resulting in the production of free fatty acids, which are used for energy, and of ketone bodies. Ketone bodies are produced faster than cells can use them. The accumulation of ketone bodies results in an acidotic state. Chronic. Macrovascular complications are a significant part of diabetes. Patients with diabetes are at a higher risk of complications, including hypertension, myocardial infarction, stroke, and coagulopathies. The mechanism by which complications affecting the large vessels occur is through atherosclerotic plaque formation. The exact relationship by which diabetes causes atherosclerosis is poorly understood. Microvascular complications, retinopathy and nephropathy, and neuropathies are often seen in diabetic patients. Diabetes-associated retinopathy is one of the leading causes of blindness in the United States. Diabetic nephropathy is the leading cause of kidney failure in the United States. Renal changes include thickened basement membranes and sclerosis of the glomerular arteries. Although poorly understood, 3 mechanisms seen in hyperglycemic states have been proposed as the cause of microvascular complications. H. Formation of advanced glycosylation end products. H. Sorbitol formation in cells through the polyol pathway. H. Oxidative stress as a result of hyperglycemia. Hyperlipidemia. Hyperlipidemia, by definition, refers to an abnormal elevation of fat in the blood. Cholesterol, triglycerides, phospholipids, and free fatty acids are important lipids found in the plasma of the human body. Because lipids are not water-soluble, they are transported in the plasma as lipoproteins. 4 major classes of lipoproteins exist. Very low-density lipoproteins, VLDLs, are formed and secreted by the liver. They are rich in triglycerides and are eventually converted to low-density lipoproteins. Low-density lipoproteins, LDLs, are formed by catabolism of VLDLs. LDLs are the major transporters of cholesterol from the liver to the tissues. High-density lipoproteins, HDLs, are often referred as good cholesterol. HDLs are secreted by the liver and intestine into the blood, where they take up cholesterol and transport it back to the liver. There it is excreted into the bile. Chylomicrons are formed from exogenous fat sources and solubilized in the intestinal epithelium. They carry lipids to muscle and adipose tissue. Elevated levels of serum lipids can be related to a number of environmental factors or diseases states, e.g., obesity, hypothyroidism, nephritic syndrome. They can also be genetically linked. Hyperlipidemia as a result of a genetic link is referred to as familial hyperlipidemia. Hyperlipidemia is important because it is a modifiable risk factor in the process of atherosclerosis, which commonly causes coronary artery disease. Atherosclerotic plaque formation is thought to occur from retention of LDLs on the endothelial surface. Asthma. Asthma is a chronic airway inflammatory disorder characterized by individual acute attacks that are triggered by environment and by genetic predispositions. It is characterized by obstruction of airflow by bronchospasm, mucus hypersecretion, and inflammation. Early acute phase bronchospasm occurs secondary to a hypersensitivity of the bronchioles to an environmental or allergic irritant that initiates an immunoglobulin E immune-mediated response. This acute phase response due to release of histamine and leukotrienes from mast cells, which cause inflammation and airway edema, thereby constricting the airway. Short-acting bronchodilators are usually successful in controlling this acute bronchospasm. During the acute phase reaction, cytokines and chemokines are also released. Their release promotes a late-phase inflammatory response. The release of these pro-inflammatory mediators promotes the activation of basophils, eosinophils, neutrophils, and macrophages. Systemic and inhaled corticosteroids are often needed to control this late-phase response.